Good afternoon, everyone, and thank you so much for joining in. I'm Dr. Kim Newell-Green, and as usual, I'll be the moderator for today's virtual Grand Rounds, which is entitled Strategies for Fighting to the Finish, COVID-19 Vaccines versus Variants. First of all, let's just handle some housekeeping. We're gonna, next slide, please show you our speaker disclosures. And I also want to remind you that CME is being provided, so you'll be sent a survey after the completion of the webinar where you can attest your attendance, and then we'll send you your certificates. Also, something that we've done new today is to add the slide deck into the handouts. It's under the questions tag, so you can go ahead and take that from now, but all of this broadcast will be put up on our website, covidroundsca.org, by this evening, and the slides will be there as well. So as the US vaccination rollout hits record numbers and experts suggest that our country will soon be swimming in vaccine, I'm really excited to have these three wonderful speakers today to give us the most up-to-date information on the state of the COVID-19 pandemic and the vaccine rollout in California, updated information on what we know about vaccines, including the newly improved J&J vaccine, and on the COVID-19 variants. We'll start with our regular guest, Dr. Erica Pan. Erica is, as she has been for many months, among the incredibly hardworking physicians and other folks at the head of our state response to the COVID-19 pandemic, and we're very grateful for her service in that role and for her time here today as she joins us yet again. Dr. Deborah Wadford has also joined us again from her position in the State Viral Lab to give us her insights into the way in which COVID-19 is mutating. And finally, Dr. Monica Gandhi, an infectious disease physician from UCSF, who has been a very active thought leader, speaker, and writer nationally during the pandemic with articles in medical journals and the public press. Is here with us. Monica's pushed our thinking on mask wearing, on reopening schools, and she now brings a very hopeful viewpoint on the impact of vaccines in our fight against the COVID-19 and its variants. At this time that seems in many ways like a turning point in the pandemic, we encounter a spectrum of responses from our public health leaders, other medical experts, elected officials, and the media about where we are and how worried to be. Some people have cautioned that many of our continued messages of caution stem from medical alarmism. I, for one, am feeling an eyes wide open optimism at this point in the pandemic, and I look forward to hearing from our speakers about where they sit on that spectrum. Before we begin, just a reminder to submit any questions you may have on the presentations by using the question box in the control panel, and we'll go over the questions as we have time at the end of the presentation. Now I'd like to turn the time over to Dr. Erica Pan, our California State epidemiologist and the Deputy Director of the California Department of Public Health Center of Infectious Diseases. Thank you, Erica.
Great, good afternoon, everyone. Thank you for having me again, and happy to give you a little bit of an update on California epidemiology, a little bit of vaccine rollout. Go ahead to the next slide. Thought I would share some information we're about to post on our website this week about what we know about antibody prevalence in the state, and some of our, our new health equity metric for vaccines, which we're really excited about, and I'm happy to answer some questions. So let's go right into the next slide. So we are at 3.5 million cases as of today. Sadly, 54,000 deaths, and total tests, almost 50 million tests that have done in the state of California. And I think a lot of reflection happening kind of in the last week as far as we first declared our state of emergency in California. I think it was March 4th or 5th. And we're getting close to our anniversary of the first stay at home in the Bay Area, which was March 16th. So it is nice, as Dr. Green was saying, that we have a lot of good news, and the light at that end of the tunnel is getting brighter. And I would say that our overall rates, the next slide, are definitely decreasing. We had this huge surge, as you can see from the blue line here, which is the cases. And so that really did peak in December and January. We were really nervous about a post-holiday bump, but we really thank Californians for, we didn't have actually a huge it was, the biggest increase was around like early January, and then has been coming down since then. The other curve, I think I've shown this in previous weeks as well. You can see the orange curve, which is hospitalizations, which certainly peaked. And as we all know, we're extremely stretched, especially in Southern California and the Central Valley, but we are on the downslope, continue to have decreasing hospitalizations, decreasing new admissions, decreasing ICU, which is that black line. And we've been monitoring very closely as well the percent of COVID patients in ICUs across the state, and that continues to decrease as well. We actually continue to do kind of ICU projections, and those continue to look good. I think what's interesting is there's decompression basically happening, and so the percent capacity varies because people are demobilizing their surge beds to actually be normal beds again too. So it makes some of the numbers we've been following a little bit difficult to be apples to apples, but overall good news that things are really improving. And then the death curve is the red curve there, and there's a much longer time lag between when those are reported to us, but also, as you can see, greatly decreasing. We're finally getting close, I think, to our last nadir, which was in sort of September, right when we were starting to reopen the last time when we first unveiled the blueprint. Next slide. And then as I started to mention, we are about to post this in the next few days, certainly this week, and wanted to share it with all of you. We've been looking at antibody prevalence across the state. We have a few different sources, a couple blood banks, so that's much more sort of less biased because it is just people coming into who are not symptomatic and for their blood testing, and then whatever we have that is legally reportable to us in our public health surveillance system. So we look at that. We've done a lot of complex epidemiology to look at it weighted and unweighted, and they're not very different. And what we can say over the last 4 weeks is that we are at about 38% across the state as far as our average across the state over the last 4 weeks of people have antibody. And of course, now that we're starting to vaccinate people, we can't distinguish if that antibody is from vaccine versus prior infection. But again, we'll talk about vaccine numbers soon. It's not a huge number yet to impact that. And then you can see by this chart, it really, of course, varies quite a bit across the regions. So our lowest seroprevalence is at 29% in the Bay Area. And then interestingly, at the southern border, and we're really taking a closer look at this especially because Imperial County was so hard hit, especially last summer, at that lower end there in the southern border. And then at the highest prevalence is in the Los Angeles area in Southern California. And again, you can see our confidence intervals. So there is a wide range there. The reason the Northern California confidence interval is so wide is it, again, is a very rural area of very low numbers. So I think just low denominators there as well. And you can see, of course, it not surprisingly, for the most part, really maps well to where we've seen the most cases in disease and where we now see more immunity. But it's really helpful to think about, as we think about vaccination moving forward, what our underlying antibody sort of immunity is right now. So I think this has been really helpful for us as we think as a state too about what our vaccination goals. Of course, we're not testing people before they get vaccination, so there's overlap, but just again, knowing that there's a much larger proportion, because when we look just at cumulative data, it's only about 9 or 10% over the entire pandemic, but this is our more recent after this big surge. Next slide. And then, a big theme over the last week it has been about our health equity and where we've seen the most disease. We know that as we look at the Healthy Places Index, which has been the social vulnerability index we've been using in California, that looks at a lot of different parameters, not just socioeconomic status, but other things that actually predict the social determinants of health, that predict life expectancy. We know that 40% of the burden of cases and deaths and hospitalizations have been in our least advantaged HPI quartile, and that is this blue line up here. And we know, so this correlates with that the highest disease burden has been in that quartile, and almost 50% most recently in that lowest quartile have detectable antibodies. And then in our most advantaged quartile, the fourth, you can see it's about between 30 and 35%. So this is kind of an interesting trend to see over time and also broken out by quartiles. Next slide. And then we do have our vaccine dashboard, and really happy again to a lot of hallmarks that we continue to meet. And we've administered 10.5 million doses here in California to date. And even more exciting, 3.4 million individuals are fully vaccinated. And that's about 11% of people over 16 years of age and older as far as who's eligible for this vaccine as far as the age parameters. So making a lot of progress. We've really ramped up over the last few weeks. Actually, I think the next slide is about that ramp up. So you can see again, early on, right around the December holidays and during the surge, we were first getting started, and now we're averaging about 200, close to 190 to 200,000 vaccinations per day as far as what's reported to us. There sometimes can be, again, a delay. We've really improved our data collection around this, continuing to work on improving that. The little slump there in the green bump there is when there was the large storms and there was a delay in vaccines getting to us because of the storms in other parts of the country. But you can see there was a lot of catch up there. And again, there's a delay here in that last week. As we get the reports in, I fully anticipate that will be back higher above the sort of the closer to the purple there. So anyway, you can see we're continuing to ramp up, and really our rate limiting capacity factor at this point is vaccine supply. Next slide. Last thing I'll say about vaccine supply before I talk about eligibility is we're really excited, and I know another topic I'll touch on, and Dr. Gandhi might be talking more about the Johnson & Johnson vaccine. We're getting an allocation that's delivered this week, and then unfortunately we are not getting an allocation next week and the week after. It sounds like there were some manufacturing issues, so we're so excited about this new vaccine and getting one shipment of a little bit over 300,000 for the state, and then none for a couple weeks. And then we're waiting to hear how much we'll get after that. It's going to be a rough couple weeks as far as supply this upcoming 3 weeks, because we're finishing a lot of second doses and not getting a lot of new vaccine. So I think that, along with some of the shifts, are going to cause a lot of, I think the hardest part right now is that we just still do not have enough vaccine for all the people who are eligible and all the people who want and need to get vaccinated, but making huge progress as I just showed. So on that note, just kind of reiterating, because I know there's been some confusion about who's eligible. So Phase 1A was healthcare workers, skilled nursing home, staff and residents, long-term care residents, and then Phase 1B was individuals 65 and older, and then individuals in 3 key sectors that are at occupational risk of exposure. So agriculture and food sectors, education and childcare, and emergency services. And we have a detailed list with some of the caveats and a link to our essential services, essential workforce list that people can look at for definitions of these people. Next slide. And then beginning March 15th, so next week, healthcare providers can use their clinical judgment to vaccinate individuals 16 to 64 who are deemed to be the very highest risk to get very sick from COVID-19 because of the following severe health conditions. So this was adapted from the CDC list of high-risk conditions for COVID-19, and then our drafting guidelines work group, which is a multidisciplinary group, clinicians, public health ethicists, that tried to narrow that list a bit, just because, again, we wanted to narrow that to the highest priority. I think smokers were on the list, which is a much larger number as far as trying to kind of be systematic in a next subgroup. So this is the list of conditions, and then also making sure that we also have eligible people who have developmental or other severe high-risk disabilities that also put them at high risk for life-threatening illness or death, or if acquiring COVID-19 would limit their ability to receive ongoing care or services vital to their well-being or survival, and also that adequate and timely COVID care would be challenging as a result of their disability. So we're still finalizing a fact sheet that will come out very soon as well about implementation of this. We know there's a lot of concerns, and one of the many places we're trying to strike the balance of having some way to verify that people have one of these conditions, but not having barriers to getting vaccinated. And as we all know, there's been that's just a difficult challenge, I think, for those of you on the front lines who are vaccinating, especially at these mass vaccination clinics. We don't want to make it harder for the frontline staff who are screening, but we also want to try to make sure that people have at least something to show, and we've been calling it, our implementation work group has called it the speed bumps, to show some documentation. Certainly we're going to encourage people with these conditions to get seen within their healthcare system if their healthcare system has vaccine, and to get it there as opposed to these mass vaccination clinics, but we also want to make sure that people have sort of choices on where they can get vaccinated. So more to come very soon, I think in the next coming days, that will get posted on our website, disseminated about kind of eligibility language on verification, just performing. It's going to be, relatively simple as far as some sort of documentation, whether it's a letter. A lot of our state departments of social services and developmental services are going to issue letters that are personalized to their people we serve that meet these criteria. And then again, trying to have that balance for in other settings, how to make sure people can sort of show some level of verification like they do for their occupation. Next slide. And then our big announcement last week was that we want to meet certain benchmarks as far as equity. We announced as well that as I mentioned already, the 40% of the disease happens in our least advantaged quartile. So we really are starting to allocate now and making sure that vaccine is allocated to individuals in that to match that disease burden. So that is starting to happen, and again, really wanting to prioritize, and I'll show you, we have a lot of catch up to do as far as how much vaccine's already been distributed by quartile. So we came up with some benchmarks to help mobilize our entire state and broadly across communities to make sure we're meeting certain benchmarks to get vaccine to the people that need it the most. And so when we meet a certain benchmark, we're going to actually shift the tiers and thresholds so that the red tier will be slightly different. And next slide. So I'll talk more about the red tier in a moment, but this is just to show you where we are. This is a few days outdated, but you can see here again, the left side of the slide is the least advantaged quartile, and HPI quartile 4 is the most healthy community conditions. And unfortunately, we are disproportionately vaccinating those who are at least risk of being exposed or of serious illness. So we need to sort of change that, and that's why, again, we decided to make sure we're allocating 40% of the vaccines to this HPI quartile 1. But this is where we are now as far as percentages of first doses and then second doses. So again, our most healthy people are getting over double the coverage that those individuals in the HPI quartile 1. Next slide, please. And then this is actually just the number of doses, especially because our benchmark is about, once we get to the 2 million mark for HPI quartile 1 is our first benchmark. And this is again a couple days out. I think we're at 1.85 as of yesterday, and I haven't seen today's numbers. So I think we will meet this benchmark in the next several days. But this is again showing kind of where we are by quartile and that we really want to catch up on this HPI quartile 1. Next slide. So what happens when we get to that benchmark? This is where we will shift our tiers. So right now, the current row is where we are now as far as the thresholds for case rate per 100,000 per day. And when we get to that 2 million doses administered, we will then be shifting that the purple tier is only those counties whose case rate is above 10 cases per 100,000 per day. And so really it impacts primarily counties whose case rate is in the 7 to 10 range, which we are posting, I think, as we speak. And we do have several counties moving forward from purple to red now, given our current case rates. And there are others that would shift when we meet this other benchmark to be in that red tier. We're going to look at when that benchmark gets hit. We're going to look at the data from run today and posted today. And again, counties that have been in that range will kind of earn a red week. And then if they've had a prior week in that same case rate range, then they will actually be able to move immediately into the red tier. Otherwise, they'll wait for the next data run to be assessed again. And once you get 2 weeks of red metrics, then you get to move into the red tier. And then once we meet the 4 million doses, we will actually make some changes in the orange and yellow thresholds too, to make it a slightly higher case rate where we can where counties can move into that orange or yellow tier. And the idea again being that as we vaccinate our most vulnerable, that we can tolerate higher case rates because we're presuming, and we're looking really closely as well as the number and proportion of people that are being hospitalized and their ages and things like that to see that impact. But that's sort of the general idea of this framework for having benchmarks about vaccination and how that impacts where our thresholds are for allowing more activities in different tiers. Next slide. And then just briefly, as far as allocation and equity, we're working closely with the Blue Shield as our third-party administrator with 5 key plans for vaccination equity. So allocation, I have already mentioned that 40%, and then the network. So the state vaccine network really needs to include appropriate access in disproportionately impacted communities. So that can be everything from making sure we have excellent navigators, which is part of the community partners part, this next part of the strategy, supporting community-based organizations and other partners that are already trusted leaders and organizations to reach target communities and having them help with translation, making sure there's extended hours within the network, transportation services if needed. There will be ways to do mobile vaccination, especially as we increase our supply. Working on whether there need to be incentives as well. There's going to be kind of carving out my turn codes for certain populations and partners so that we can really try to protect appointments for those that we're really trying to reach. And then really using our real-time data analytics to adjust and intensify these efforts and resource allocation to meet these equity goals. So there's going to be weekly vaccine allocation reports that come to us at the state and working with the TPA to make sure that we're reaching the geography and the providers we want and that those providers are reaching the populations that need to be met. And then, of course, really ongoing public education, providing consistent messaging. Again, we're working with a lot of community-based organizations, trying to think about a lot of different audiences, especially those who have not had vaccine confidence, and really tailoring messages to different populations. We've just partnered with a group called Duncan Shannon, who's going to really do ongoing work with focus groups and communities of color and others who need more information and need more information in ways that is, that's sort of user-friendly to those populations. So those are all kind of components of how we want to get to our vaccination equity. And that may be my, next slide. And I think if Dr. Gandhi is talking, and I think I'm getting short on time, so I won't spend a lot of time, but just to say, we're all really excited about the Johnson & Johnson vaccine. I think you all know it is out and available. I already mentioned the supply issue. Next slide. Next slide, please. And just to kind of quickly, note that not only the ACIP, but we at the state, we've consulted with our Western State Scientific Safety Review Group as well. And again, very excited about the efficacy of this vaccine. It has strong protection against severe COVID-19. So over 93% vaccine efficacy against hospitalizations and no COVID-associated deaths in the about 40,000 people that they studied. And we're trying to also message and come up with communications around the fact that the Janssen phase 3 trials are not as comparable with the mRNA vaccine, so you can't quite compare the efficacy numbers that are out there. So lots more to come from us about communications on that. Again, very excited that we have this, next slide please, vaccine that is safe and highly effective, but also just one dose, so that's the one and done. It's easier to transport and store. It doesn't need to be in this ultra low temperature or even frozen. It can be in refrigeration, so much easier to use in a lot of mobile sites and other places. Really important tool to help us. There's also some great evidence, and again, I apologize if this is too much overlap with Dr. Gandhi later, but decreasing transmission. So they did actually do some studies to look at people who are asymptomatic and moving forward, and there's some evidence that it does decrease transmission and does a little bit better against variants. So that's also very exciting. So our communication to all is that the best vaccine is the one you can get when you're eligible, and that we have 3 great options in our toolbox now to help us fight this pandemic. Next slide. And this is just a list of resources for providers. Next slide. And I think I'll stop there and see if Q&A. Thank you.
Thanks so much, Erica, as always. And I know your schedule is changing up to the last minute. Or just to check in, are you going to be able to join us at 1 for the Q&A, or should I ask you a few questions right now that are? Oh, you're muted.
I think it's probably better to do some now, actually. Thanks.
Okay, let's do that then. So one thing that I've been curious about, and I didn't see a slide, you may not know this data off the top of your head, but what's the data on the percent of healthcare workers in California, and then the percent of long-term care residents who have been vaccinated at this point? Do you know those numbers?
I have seen the numbers on the long-term care, especially from the Federal Pharmacy Partnership, but I don't have them off the top of my head, but I can maybe sort of certainly in the future can report that. And the healthcare workers has been a harder one to gather because of the way electronic health records work. The data on occupation doesn't get transferred, and there's some technicalities around that. So I don't know that we have great data on that yet, actually, I know within systems, it's been really helpful to hear. So, you know, how Sutter is doing and how Kaiser is doing as far as, but as a broad number, I don't think we have a great pulse on that at this point.
Yeah. And do you have a sense, I mean, we've seen reporting from across the country about places in which there are some percentage, if not a large percentage of healthcare workers who are actually vaccine hesitant and still waiting and or refusing, frankly. Do you have a sense of how that's looking in California, sort of at least anecdotally?
Yeah, anecdotally, I think it's been like other aspects of the pandemic, really regional. And so I think there's been a lot higher uptake in places that have also been, you know, had early mask orders or more mask sort of adherence, and a lot less in areas of Southern California, for example. I've heard anecdotally there was a lot less uptake, but I haven't heard recently as much about that. We do have data, which I meant to present on the over 65 too, and I think we have, I think it's over 25% of our 65 and older are fully vaccinated now. So we've really made a lot of progress in that, which is much easier to kind of look at the data. But that is a great question we should follow up on as far as healthcare workers and to see how we can better get at that.
Great, thank you. And then now, especially with the Johnson & Johnson vaccine coming out and it being so much easier to administer in smaller places, where are we on whether small and solo practices are going to be getting the vaccine to administer, especially now with the focus on the medically vulnerable when those practices really know those medical histories?
Yeah, I mean, there's a two-part answer to that. I think it's largely going to be up to Blue Shield at this point, the third-party administrator. And I think right now with such a limited supply still, I think it's very early to be, you know, I think there's still, with such a limited supply, we really still need to work with places where you can really, you know, I think there are more and more collaborations happening. And then as you also probably know, and you know, in the future, happy to talk more about the federal partnerships with the FQHCs. So there's some separate allocations happening that way. But I think, you know, I think until we really have a much, much larger supply, it's going to be harder to provide vaccine to all the solo providers. But yeah, I'm looking forward to a way as, I don't know if you said raining vaccines or, you know, to a time. And, you know, it sounds like they're saying by May, we should really have plenty of vaccine everywhere. So I'm really looking forward to that time because it is challenging for everyone.
Yeah, I think we all are. And just because we know you have other important work to do, maybe I'll ask one more question if that's okay. You alluded to the notion of providing incentives, perhaps financial payments to some parties as we try to get everyone vaccinated. I wonder if you can comment on this kind of your thinking around how that might look and the ethics of that. And then also comment perhaps on if there's any talk about requiring vaccine in certain workplaces.
Sure, I'll answer those in reverse order. I mean, we've, and there's two different layers of mandating vaccine, I guess. I think workplaces can certainly start to consider doing it. I think as a state or for schools, of course, for schools, we can't do it when we don't have a pediatric vaccine yet. But I think a lot of the concern is with vaccine confidence and with it's never been done before with a vaccine that's only under emergency use authorization as opposed to one that's been, you know, fully beyond that level. So I think collectively we have a concern about mandating quite yet when, you know, we really need to work on vaccine trust and confidence. And as we all know, there's been a lot of anti-vaccine sentiment out there, and some of that really gets louder and pushes back further when it's mandated. So we're really trying to work more on education and outreach and providing good information, and again, working with trusted messengers, which is a good segue to the question about, you know, I think, you know, it takes time, and we can't just ask people to volunteer, I think, to help work with the communities that need to be worked with. So again, working with community-based organizations and people on the ground, I think we want to really be able to fund them to do the work with the communities they already work with on how to be able to, again, whether it's help them sign up. I think the other big issue that's coming up with, My Turn is a great statewide thing, and we're continuing to onboard more and more that we'll need to use that to sign up to either find out when people can be vaccinated and where, but not everyone has the access to the technology or the language, so we need people to be intermediaries, and there's some models already happening with that. So I think that's really the idea behind it. So but I hear you, there's a delicate balance between sort of incentives, but I think on the other hand, we are seeing a lot of, based on the data I just showed about HPI quartile 4, a lot of really kind of resource people are finding, going to places that, they can travel and find and figure out and be on their computer or phone and sign up right when the slots open. So really trying to figure out how to reach populations that don't have those resources that we really want to reach, and how do we do that? And I think it really is through intermediaries.
Great. Well, thank you so much, as always, for joining us, Erica, and we look forward to seeing you again soon.
All right. Thank you for having me. Take care.
Next up, we're going to have and welcome Dr. Deborah Watford, who is the chief of the Viral and Rickettsial Disease Laboratory at the California Department of Public Health. Thanks so much, Deb.
Sure, absolutely. And thank you so much for having me back. And I'm happy to be here to talk about and to give an update on the SARS-CoV-2 variants of concern and variants of interest. Next slide, please. And so here's a roadmap for my talk today, and I'm going to kind of review some of the important spike protein substitutions and mutations that are important when we talk about the variants. Then we'll focus on the current variants of concern and touch on some of the variants of interest. And then I'll close with a summary and some key points. Next slide, please. So why is this concern? Why do we have so much talk? The variants, it's now part of our vernacular. every day on the news, you hear about these variants, and I've heard Dr. Eric Topol term them as scariants, right? So I think knowledge is power. Let's approach this from a perspective of trying to understand what's happening. And so the variants really seem to, they do imply that a virus has acquired mutations, and so therefore they have become a variant from the wild type. And some of these mutations and substitutions can confer an increased ability for the virus in some cases to transmit more easily, and infect the host cells more easily. Also may potentially confer an increased pathogenicity as well as virulence, may allow the virus to evade the immune response, which could lead to reinfections of hosts that have already been infected. And then also, by virtue of immune escape, perhaps escape vaccine immune responses, which may impact and reduce vaccine efficacy. And then lastly, for the diagnostic tests that we use to detect the virus in hosts, if we have changes in the genome of the virus and we have tests that actually target that genome, we may lose the ability and have a failure of our diagnostic test. Next slide, please. So everyone, I said this last time, I think it's so critical to understand this and remember and appreciate that all viruses mutate, so, and especially the RNA viruses. So just because we hear about variants, it doesn't necessarily have a significance, but there are times when it does. And so I've provided here a list of key spike protein mutations and substitutions for SARS-CoV-2. I'm not going to go over each one. We have a very limited amount of time. It's a good reference in case you're interested. But one thing I do want you to appreciate with this list is a couple of things. So the spike protein is the key protein for this virus that interacts with the human host. And so it's this protein that we see, that our body sees, and it's how the virus gets into our cells to infect us. It's also how we recognize that part of the virus, and we can generate an immune response. So a lot of these mutations relating to the spike really are sort of forced or due to selective pressures from that interaction between the virus and the human host. And again, the spike is that key interface. And so the overarching themes here is that the mutations can either confer an increased ability for that virus to bind to the host cell, or these mutations can confer an immune evasion response from the virus. Next slide, please. So I like this picture because it sort of depicts a couple of possibilities in terms of how viruses will acquire mutations and how some will lead to disaster for the virus and extinction, and then others might lead to a better fate for the virus and poorer fate for us humans and success. So if we focus here, this really shows a radiation of the different possibilities for viruses. And the A clade, starting at the top, it really was the Wuhan virus. And you can see that there are a couple of branches that emanate from that. And most of them, you don't see a lot of radiation. And in fact, that one from Seattle is no longer seen, it's extinct. However, if you move down to the righter part of that picture, you see the B1 clade has really been successful. And coinciding with that success seems to be the acquisition of the D614G mutation in the spike protein that has been shown to increase the transmissibility and infectivity of the virus. And notably, all the viruses circulating globally now have this particular 614G mutation in the spike. So all of the B1 lineages that we see here have that, and then some of them have these other mutations, and so I want to call those out. So in the red square on the left, you'll see the E484K mutation of the spike, and that has been shown to allow the virus to escape the immune response, at least from an antibody perspective. And then the other hallmark mutation is the N501Y mutation, and that has been shown to increase the affinity, the binding affinity of the spike protein to attach and bind to the host cell receptor. Next slide, please. And we'll revisit that picture in a minute. But let's now consider the variants of concern of the VOCs, and those are shown here on the left of the screen, and then we have the variants of interest, or the VOIs, on the right. So let's focus on the variants of concern. And so we have three recognized variants of concern that have been detected in several countries. The most predominant one in this class would be the B117, and that was originally or first detected in the United Kingdom and has now essentially spread throughout the globe. It's certainly here in the United States. There's about 3,000 detections so far in the United States, and the CDC and others have predicted that the B117 will actually become the predominant variant in the US by the end of this month, March. Okay, so then the P1 is originally first detected in Brazil, and it is shown to be highly prevalent in Brazil and also in other countries, including the US, but at lower levels. And then lastly, on our list of VOCs would be the 351, and that is the one first detected in South Africa. And if we move to the right now and talk just briefly about the VOIs, because I want to focus mostly on the VOCs, but the 429 and the 427, those were first detected in California, and we're calling that, in California, we're calling this the Western variant. And it actually is not only in California, but is in probably about 44 or so states. So it is pretty much a United States variant. And then the 526 at the bottom right, And that was most recently described by Columbia University researchers in New York City, but has actually become now about 30% of all the viruses sequenced are of this 526 variant, and in New York and New Jersey. So they're keeping an eye on it. And interestingly enough, we have had some detection of the 526 here in California as well. So it's making its way around. Next slide, please. So one of the things I really want to call attention to for the variants of concern is the number of mutations that we see, particularly in the 117 and the P1. And I've circled them here so that you can see. And there, a lot of those mutations are in that notorious spike gene. So again, we talked about probably why, but what's really unusual is that the number of mutations seen, and we just first detected the 117 in September, and it really didn't hit our sights of line of vision until December. And in that short amount of time between September and December, acquiring this many mutations is unusual for this particular SARS-CoV-2. And likewise, you see a similar increased number of mutations from the P1. So it's hypothesized that really the only way this can happen, because it's not going to be based on the mutation rate, that likely, or the hypothesis is that there was a human host that was immunocompromised, was not able to fight the infection off, and so they had a long-term infection. And so given that time, the virus was able to fine-tune and escape the immune response generated, if there was one, in that host, and fine-tune its replication strategies within that host. And then eventually that was transmitted to other hosts. So that's the working hypothesis. And it does explain the accumulation at such a higher rate than we would expect for these variants. Next slide, please. All right, so now I'm just showing you a linear depiction of the spike protein, and I want to call your attention to a couple protein mutations here. So the first one, next slide, please. The first one is the D614 gene. I told you that that's present now in all the viruses, so we would expect to see it not only in the top three, which are the VOCs, but also the bottom three that are more variants of interest. Next slide, please. But we also have this 501Y, which is in all of the variants of concern, and that's the one that increases the binding ability of the virus to the host cell. Next slide, please. And then in the 351 and the P1, and actually the P2, we have that 484K mutation, the one that allows for immune escape. And next slide, please. So if we just kind of look at that, but there's sort of, again, another overarching theme here. We have this increased transmissibility, increased infectivity, and then the potential and the acquisition of an immune escape mutation. Not shown here, but I want, again, to call your attention to it, is that there is a small cluster of cases in the United Kingdom for the B117 where we've had the emergence independently of the 484K. So now we have sort of this, scary situation, again, similar now to the South Africa 351 as well as the P1, where we have the 501 coupled with the 484. And so keeping an eye on that. Next slide, please. And I want to show you the three-dimensional picture of the spike protein. And so again, it's sort of lined up on top is that linear depiction of to orient you in terms of the color. So it's color coded. So we have the blue shows the N-terminal domain, and then the purple is actually the receptor binding domain. And then we have the rest of the spike protein. But so a spike protein in the virus actually is composed of three or a trimer of these proteins. And if you look at the left side, that's just looking on side view of the spike. And you can see that the purple on top there, that's again the receptor binding domain. And then the light blue is sort of, it's the N-terminal domain, but they liken it to a hand. where you have the hand is here and it's grasping, so that would be the receptor, and then you have the forearm, which would be that light blue, the N-terminal domain. And those two domains together, when they acquire mutations, it certainly has the potential to impact not only the binding of that receptor, but also potential blocking or evasion from antibody binding to stop infection. Going to the right side of this picture, it's looking at the top of the receptor, and you can see the three different receptor binding domains that kind of come together in like a little clover, and that's where the business aspect of the virus is, where it binds to our host. So if we have antibodies that can recognize that by virtue of our vaccines, we could block the binding and stop the infection, and that's really why we do this at all. Of course, that the clever, or the virus has certainly had time in some instances to escape the immune response, as we've talked about. Next slide, please. All right, so let's go back to this picture real quick, and I want to call out the red circles, or those are the variants of concern that we talked about, and you can see that those three have the 484K for 351 and the P1, but also, as I mentioned, even the B117 has now emerged, a little cluster right now, the 484K, but they all three have the 501Y mutation. Next slide, please. So I put together this sort of summary cheat sheet on the different variants of concern. You can look at it at your leisure. That's also a source from the WHO. Most of these are the variants of concern. They show an increased transmissibility either in vitro or epidemiologically, and also show the tendency for immune escape, except for the 117, the canonical one. And then the reduced impact or reduced vaccine effect, you can see that there, and I'm sure Dr. Gandhi will probably talk about that. Next slide, please. Now we'll just briefly hit on the variants of interest, and you can see them here in the picture. They're circled in purple. Next slide, please. Thank you. And here's the chart on this, and there's not too much information on it. There have been studies put out for the so-called 427 and 429, that West Coast variant. There's another variant that has emerged called the 525, and that was first detected in the UK and Nigeria, and they're keeping an eye on it because it has that 484K mutation, but not a lot has been known about it, but it is starting to pop up in different countries. And then lastly, the 526, again, we only we infer that there's an ability to escape the immune system and response, but studies are ongoing for that as well. Next slide, please. So just quickly to close up, SARS-CoV-2 mutates. We expect it. It's supposed to, not a surprise. Thousands of variants therefore arise. Most of them will die off. Some will persist. And the question is, those that persist, what does it mean? And one of the things we use to sort of understand what that means is the acquisition of spike mutations like the 501Y and the 484K, etc. But the take-home message here is that don't consider these scariants necessarily. Really, regardless of whatever variant it is, we have to adhere to the non-pharmaceutical interventions of mask wearing, hand washing, physical distancing, and we have to encourage getting vaccinated. That is going to get us to the other side. Next slide. I think that's it. Thank you.
Thank you so much, Dr. Wadford. That was a great way to tee up our final speaker, Dr. Monica Gandhi, Monica is an infectious disease doctor. She's a professor of medicine and the associate chief in the division of HIV infectious diseases and global medicine at the University of California, San Francisco. She's also the director of the UCSF Center for AIDS Research and the medical director of the HIV clinic known as Ward 86 at San Francisco General Hospital. Monica's research focuses on HIV in women and adherence measurement in HIV treatment and prevention, but most recently, she's really been working very hard, as I said before, on how to mitigate the COVID-19 pandemic. So thank you so much, Monica.
Okay, thanks for having me. I'm going to tell you about the vaccines. And it will relate to everything that Dr. Pan and Deb talked about with the epidemiology and with variants. So let's go forward to the next slide. You know, we're going to talk about vaccines and their mechanisms. We're going to talk about immune responses, which actually has to do with the variants. We are going to talk about the outcomes of the trials, specifically the ones that the vaccines that are authorized in the United States. We won't go over all of them. We'll talk about that vaccines do decrease transmission. We have data on that now. And worrying or not worrying about the variants, at least in terms of the immune response, and then what we can do after vaccination, which has relevance for many things, including schools. Next slide. So, you know, there are actually 9. I said there are 8, but there are 9 vaccines right now with phase 3 clinical trial data out for their efficacy against COVID-19. It's a very exciting time. I am actually going to focus on these top 3, Moderna, Pfizer, Johnson & Johnson, but I wanted you to have this slide so that you can get either the press release or the full paper for each of them. One I did not include on the bottom because it just came out is Covaxin, which is a new vaccine released in India. Next slide. So except for the last 2 that I had on that former slide, which are called the Sinovac and Sinopharm vaccines, which are inactivated virus, all 6 of the others besides those have to do with the spike protein of the virus. So the way the virus interacts with the cell is this sticking out protein that comes out called the spike protein, and then it binds to the cell at a spot called the receptor binding domain, and all of them use the in some way either code for the spike protein or give you the spike protein. And as I'll show you with the success of the vaccine trials, this certainly was the right candidate to choose. Next slide. So of those spike protein vaccines, then there are 6, and there are 2 mRNA vaccines. And what that is actually taking the genetic material mRNA that codes for spike protein, which is mRNA, and they put this lipid nanoparticle around it, inject it into the body. Those are the Pfizer and Moderna vaccines. The mRNA comes in into your cell, and then your body uses what's called your translational machinery to make that mRNA into the spike protein. And then your body says, I've never seen this spike protein before, and they raise a vigorous immune response against that. The adenovirus vector DNA vaccines, there are 3. Those are 1 that we have in this country, Johnson & Johnson. There's also 1 in the UK and Europe called and many other places called AstraZeneca. And then there's another one, Sputnik 5, that was developed in Russia. The adenovirus DNA vectors take a virus that causes very harmlessly a cold, or and actually it doesn't even cause a cold in us because these are non-replicating in the human body. But the Johnson & Johnson, for example, is a human human adenovirus that comes inside with the DNA that codes for the spike protein, and then that's just really the vector, the adenovirus, to get the DNA, and you make the DNA into mRNA, and the same process happens. You make the spike protein. And then the Novavax vaccine actually is giving the spike protein and the receptor binding domain itself. So next slide. The reason I want to show this slide, though I recognize it's you know, it is the immune system, it is important to remind ourselves of immune responses, both to natural infection and vaccines. Remember, the immune system is not antibodies, though that was really interesting data that Dr. Pan presented with seroprevalence that could even be not even represent everyone who's been infected, because antibodies can fade. There are 2, though I think it's a good marker of having had the virus and immunity, but there are 2 major responses in the human body to a virus, and actually one of them matters more than the other, which is T cells. So there's antibody responses; those come from B cells to plasma cells to antibodies. We're used to seeing antibodies. We see it in the news all the time. We see seroprevalence studies like the one presented today. But it's actually the T cells that are our main immune defense against viruses. Once our antibodies have abandoned us, it's the T cells that are going to long-standing protect us against viruses. And it's T cells that are raised against measles vaccine that we have 34 years later, after measles vaccination, for example, and counting. And it is 2 types of T cells that matter. And the reason I'm telling you about this is all the vaccine trials measured. What you want to raise against SARS-CoV-2 is a CD8 specific T cell and also what's called a Th1 CD4 cell. So a helper cell that's along this Th1 response, and then CD8 cells, which are cytotoxic T cells. And interestingly, next slide, unlike other vaccine trials, these vaccine trials actually measured these T cells. They proved to us that that these vaccines are generating very rigorous and vigorous and robust T cell responses in us after vaccination. So again, just looking at those top three is the ones authorized in the United States: Moderna, Pfizer, Johnson & Johnson. I already told you Moderna and Pfizer are mRNA vaccines. You know that Moderna and Pfizer are 2 doses and the Johnson & Johnson is a 1 dose. And their phase 1-2 trials truly measured neutralizing antibodies, but also really recorded what we needed to see, which is a strong Th1 CD4 cell response and a CD8 response specific to SARS-CoV-2. And also when they gave these 3 vaccines to macaques after a macaque had a vaccine, they re-challenged the macaques. They were unable to get infected. As you can see, these 3 trials were studied in large numbers of individuals. Those are the participants who got the vaccine, that's column 5. But of course, half didn't get the vaccine, they got placebo or a saline shot. And I'll tell you more about these trials in a bit, but I do want to point out this particular column that's highlighted here, that any COVID-19 related hospitalization or death, the worst outcome that you could ever have, happened in the people who got placebo. So they were almost 100% protective against the worst outcome, all 3 of them, of COVID-19, which is severe outcomes, which is hospitalization or death. In fact, the Moderna, there was just 1 person who got hospitalized who was in the vaccine arm, and that was adjudicated by the FDA. We saw that later. Otherwise, almost 100% protective against the worst outcome. And then I'm going to go into the Johnson & Johnson, but they were also equally protective against severe disease, very highly protective against severe disease across South Africa, Latin America, and the US in the case of Johnson & Johnson. And severe disease being defined as a couple of people, actually only 5, who ended up being at home and didn't need to go to the hospital, but still were very sick at home. And then the variability in responses that we're going to talk about with the Johnson & Johnson vaccine occurred against mild disease. And I'll give you more detail on that. But if you go down that yellow column, all the vaccines, this very scary, terrible outcome that led us to even pay attention to SARS-CoV-2, which is hospitalizations and deaths. These vaccines are highly effective, which is why I say the spike protein was the right thing to choose. Next slide. The reason I'm harping on T cells is they're terribly important for doing exactly what I just said. They will protect you against severe disease if you see reinfection again. Say you get a variant like 10 years down the line, and you get exposed to a variant, your T cells will come out and protect you, and I'll explain that later. But T cells really are the arm of the immune system that modulate the severity of disease. It's why actually in places like India, there's a postulation that we've been exposed to other coronaviruses, cold coronaviruses, and we have cross T cell immunity from those other coronaviruses, which may have protected against severe disease in places like India. But certainly this is a very good study up on the top right, highly functional virus-specific cellular immune response. I want you to look at that paper if you have time to understand what T cells do to help you get asymptomatic infection if you're reinfected rather than symptomatic infection. You wouldn't even know it. Next slide. So let's go on to the next slide and drill down on a few of these details of the phase 3 trials of the 3 vaccines that are authorized in the United States. Next slide. Looking at Pfizer. The reason I want to go over these demographics with you is I want to persuade you they're not only enrolling young, healthy people. This is a common thing I get in the public that, oh, well, they didn't enroll anyone who was older. And so not true. There was a real attempt actually to enroll people who were at risk. So go back to that Pfizer, or go one more down. One more, thank you. So the Pfizer trial, which is published in the New England Journal, enrolled over 40,000 participants. These are 2 shots, 30 micrograms, 3 weeks apart. And of the over 35,000 that were reported on in this study, half were female. Not great diversity, but not as bad as often our drug trials. There was an attempt. 82.9% white, but 9.83% African American, 28% Hispanic, Latinx, because you had to actually be at risk, and there were essential workers in this trial, because they certainly weren't giving people COVID-19. They were just saying, go and interact as you usually would. And there are many essential workers, including healthcare workers in this study. 21% were over 65. So there was an attempt to enroll older individuals who are more at risk for severe COVID. And then there were a lot of comorbidities. 35% had obesity, which can predispose you to more morbid disease. Next slide. The efficacy of the Pfizer vaccine was remarkable. The outcome was not asymptomatic swabbing every week COVID, which we do a lot of asymptomatic screening. It was actually symptomatic COVID. So you said to say, I don't feel well, and then they swabbed you. And there were 170 people with symptomatic COVID, and of those, 162 had gotten placebo. Only 8 were in those who got vaccine, and they all had mild disease. Actually, all, again, the severe outcomes that in the Pfizer trial happened from COVID in the placebo arm. So if you got it, this 95% effective is wonderful. It's really high, amazing. And then even the handful of people who got it after the second dose had mild disease in the Pfizer trial. Next slide. The Moderna is giving, the safety considerations. I do want to say there are a lot more injection site reactions with these vaccines than there are with flu. That for those of you on the call who've had them, I think you can attest to that. But grade 3 adverse reactions, fever, fatigue, and headache that occurred greater than 2% were actually just, fatigue and headache in the Pfizer. And first, the company thought they needed negative 70 degrees. There's been some re-experiments, and it looks like you can have it at cold temperatures, still not regular fridge temperatures, but maybe -5 to -13 for 2 weeks. Next slide. The Moderna demographics, also published in the New England Journal, had about 30,000 people enrolled, 2 shots, 100 micrograms, 4 weeks apart, almost half female. In this case, 25% were over 65. So an attempt to get older patients, 36.5% were participants from communities of color. 82% were high occupational risk, so healthcare workers, for example, essential workers. And again, some comorbidities, 22.3% were high risk, had a comorbidity that would predispose to severe COVID. Next slide. Also incredibly high efficacy of 196, again, the same outcome, symptomatic COVID. Of 196 symptomatic COVID cases, most of them were in those who got a saline shot. 11 were in the vaccine group. And all of those were mild. Later, they adjudicated that there was 1 person who was hospitalized after the second dose with COVID. They thought it was not COVID because the first PCR test was negative and it was positive. So 1 failure to protect against severe disease. In the Moderna trial, there were 30 severe outcomes. All 30 of those were in the placebo arm, and then there was just 1 in the vaccine arm. Next slide. Also, a lot of injection site reactions, a little higher even than, at least elicited than the Pfizer, 90%. Headache, fatigue, myalgias, arthralgias, all reported at greater than 2%, and I think this is accurate in anecdotal reports of people who've gotten this. It is more stable, however. It can stay at a regular fridge, which you'd see in a clinic, 2 to 8 degrees for 30 days, which is comforting in terms of logistics. Next slide. I want to get into the Johnson & Johnson trial because this was just authorized just very recently. February 27th, I think, was the date that it was authorized in this country by the FDA. So this was a more diverse trial, to give it credit. This was a trial that was conducted across the US, Latin America, and South Africa. 43,000 participants, so the largest, very large. And 34% were over 60, so real attempt to get older individuals, and also more diverse, as you'd expect from this, from the places that it was studied. So 59% white as opposed to those 82% that you saw in the other trials. 45% Hispanic or Latinx, and then 19% African or African American. Also a higher rate of comorbidities that could predispose to severe illness. 41% had comorbidities. So it's a trial that we like to see, at least in HIV. We like the diversity of participants, and we like the ability to choose people that could get severe outcomes. I think it's important to represent the people that we're worried about. Next slide. These are the results. Again, we don't actually have a paper on this, so just to remind you, we have the FDA full report, and that's where this data comes from. There were 468 cases of symptomatic COVID. In those cases, there were 7 deaths and 16 hospitalizations, that should say 16 and not 14, from COVID-19. and those all occurred in the placebo arm. So no one was hospitalized or died from COVID who got the shot, the one shot. Severe disease was an interesting category. It was like people who were severe, and if you look at the criteria, you're like, how did they not get hospitalized? But there was a handful of people who managed at home, and then that included the subset of those who got hospitalized and died. And across all three regions, severe disease, the efficacy against severe disease was 85.4%. Across South Africa, Latin America, and the US, the reason that's important is 95%, to speak to our previous talk, 95% of the circulating virus, at least of what they tested in South Africa, was the B.1.351 variant. And then 69% of the cases in Brazil were of another mutant lineage. So it was the differences in efficacy actually occurred for more mild disease, 72% effective against moderate or mild in the US, 64%, these I should have corrected these after the FDA report, 64% in South Africa and 68% efficacy in Latin America. So there was more mild disease that occurred with the Johnson & Johnson 1 dose across these three regions than we saw with the mRNA vaccines. Next slide. The press release didn't actually mention any injection site reactions. There were actually more serious adverse events in the placebo arm than in the vaccine arm. So it seemed to be a very safe vaccine. And there are two reasons that I want to mention why I like the Johnson & Johnson, besides the diversity, besides the fact that it was tested against the variants, and besides its efficacy against very severe disease. The two other reasons I like it is if you look at the phase 1/2 trial, you can see the antibodies keep on going up and up. I keep on calling them the gift that keeps on giving. But you know, the phase 3 trial adjudicated results after about 15 to 28 days at the most after getting the vaccine. But by the phase 1/2 trial data, the immunogenicity of this vaccine went up even after 28 days. It went out to like 60 days. So hopefully it's a gift they'll keep on giving. We'll get better protection with time. Frankly, I wouldn't want people to go full hog with the Johnson & Johnson until at least 4 weeks after, even though the CDC guidelines said 2 weeks after you're protected. If it was my parent, I'd make them wait 4 weeks based on this immunogenicity paper. And then the last thing I like about it is the UK has been rolling out very quickly an adenovirus DNA vector, that's the AstraZeneca one, with mRNA vaccines. And they have seen really great responses. They're really rolling out quickly. So it gave them an advantage to have this. And they also are not having, you know, the variant concerns with immunogenicity. So I think it'll be an example for us to have an adenovirus with our 2 mRNAs as well in this country. Next slide. Couple of other points. Do vaccines decrease transmission? I could not have told you that answer with the clinical trial data, but the clinical trial data is so December 2020 and January 2021. We have so much more data from the real world that vaccines decrease transmission. Next slide. Certainly, we thought they were going to decrease transmission. If there was a misguided media headline that said vaccines don't prevent transmission, it should have said we don't know if they prevent transmission from the clinical trials, because the clinical trials were not designed to weekly swab and see if they stopped asymptomatic infection. But biologically, it would completely make sense. Number one, vaccines produce IgG antibodies, which actually get into your nasal mucosa. We know that from other vaccines. Also, we didn't measure IgA in these clinical trials, but systemic vaccines do produce IgA. That's the one that goes inside your nose and help protect you. Third is that monoclonal antibodies, which we use for outpatient treatment, also hasten viral clearance all the way from the nose down to the lungs. And then fourth, the macaques, when you gave them the virus, again, they couldn't get it in their nose or their lungs in the challenge trial. So we always thought they would halt transmission, but what's the data we have on that? Not from the clinical trials, from the real world data published in Lancet, New England Journal, and other, now 7 papers on this. Next slide, I'll give you an idea of just some of them. This is a study from the New England Journal that looked at the rollout of the Pfizer vaccine of more than 500,000 people in Israel. And the vaccine effectiveness looks like the efficacy in the clinical trials, amazing number after the second dose, 92% reduction in symptomatic infections, but also in asymptomatic infection, because there's still a lot of asymptomatic testing going on, as there should be right now as we're rolling out vaccine. Next, that's a New England Journal study. Next slide. This is data, real world data from Israel, but I'll actually, in the interest of time, go on. Next slide. This is from the Lancet. This was published in February 2021. Sorry, this is these are healthcare workers who are in in Israel in this case, and also again effectiveness or what it looks like in the real world is just as good as these vaccines look like in the trials. They actually assessed both swabs and symptoms, so even if you're asymptomatic, they would swab, and saw after 2 doses rate reductions of 85%. Of symptomatic and asymptomatic infections. So very exciting that it's going to reduce your chances of giving it to someone else, but certainly, of course, of your own ability to get infected. The real world looks like the trials. Next slide. Lots of other studies on this. This is another study, real world data from Israel just came out the other day, just amazing, reduced severe disease by 98%. Again, the real world data is looking just like the clinical trials, just amazing in terms of what we're seeing with plummeting hospitalizations and deaths. Similar data actually from the nursing homes in the United States, very low hospitalizations now that we have mass immunized long-term care facilities. Next slide. And this is another, this is a preprint with the Lancet, but this is in England, the vaccinated healthcare workers, they were swabbing them every 2 weeks, and sort of no point because after 2 doses, 86% efficacy in reducing both asymptomatic and symptomatic infection. So not just getting disease, but getting it in your nose, which would herald an ability to pass on to others. There's more than these papers. I'm just going over some of them. Next slide. So will vaccines work against variants? I want to answer that by going back to my original explanation of the immune system and what helps, what covers us, what's the main arm of the immune system that protects against viruses. We know this very well in HIV because if you hurt T cells, you don't have a good ability to fight viruses effectively. So this is a paper, actually, I love this paper. This is showing us that with natural infection, the T cell response is so robust, it's such in breadth, and it's not just measuring a couple of antibodies, which is what we do when we look at neutralizing antibodies after natural infection or vaccination. There's such a broad, the CD4 cells that you get from natural infection go like on multiple epitopes around the virus, including multiple epitopes across the spike protein, CD8 cells as well. It'd be very hard to escape with a new variant, your T cell protection that you gain from natural infection. And then next slide, this paper done by the same group shows the same thing in terms of response to vaccines. This was a study that looked at SARS-CoV-2 specific CD4 and CD8 cells, not just from natural infection, but they actually looked at people who got mRNA vaccines, and then they exposed their blood that had these nice robust T cells against a non-variant, against what's called the ancestral strain, to B117 that you heard about, B1351, the P1, the California strain, and there was no difference seen in this robust T cell response after you've had vaccination. They were equally able to combat all these variants. So I think it's okay to say the word scariants. Let's not scare our populace too much with talking about at least loss of immunity against variants. The point is, just like the first 2 speakers, is to get the population vaccinated, and we're doing a great job in California. Next slide. I do want to just say this from Dr. Warner Green, because I admire him a lot. He's someone at UCSF. He said about the Johnson & Johnson vaccine, even with the South Africa variant, the Johnson & Johnson protects you from severe disease, having to go to the hospital and dying, and frankly, that's what you want from a vaccine. That's fantastic. You may have a runny nose or a mild upper respiratory tract infection, but you're not going to develop life-threatening pneumonia and require hospitalization, and I'd sign up for that type of vaccine any day. And that is what I feel about the Johnson & Johnson 1 dose, but there are other arguments to favor it, including the logistical aspects of getting it out. Next slide. So I think I've already convinced you, I hope, not to worry about the variants in terms of the immune response. And we've already heard about how they've emerged, and that's been really there. That was a really great talk. And then let's go to the next slide, since I've already covered this. That said, we do want to tamp down transmission as we increase vaccine rollout, which is why California's easing of restrictions has been prudent and is following a tier-based approach, but also giving the population some leeway as the vaccines increase, which I really approve of, especially for outdoor activities like amusement parks and outdoor sporting events like Governor Newsom announced last Friday. So you want to kind of slowly ease your restrictions as you're getting your vaccines in place. We're doing a great job with that. Next slide. And those slowly easing of restrictions, because the three most important non-pharmaceutical interventions, this is a paper we had in Lancet ID this week, are masks, ventilation, and distancing. And if you have good masks, then your distancing can be less, or your ventilation could be less, or if you're outside, your masks don't have to be perfect. So the kind of a complementary approach are non-pharmaceutical interventions to COVID transmission. Next slide. But I really applaud, I don't actually want to go into masking because I don't think this is what this talk was about. So let's go to the next slide. So the CDC guidelines gave us this hope. They gave us this optimism. This is from yesterday. There's a lot of good guidelines that came out from CDC yesterday. Vaccinated and vaccinated people can be around each other without masks and distancing. Vaccinated around the unvaccinated, well, if they're not susceptible, like a child in a home when a grandparent is visiting, they're not susceptible to severe disease. And also all this data that we really can't give it to people after we're vaccinated. I just told you about the 7 studies. The CDC actually did say, yes, it's fine to go visit your unvaccinated relative if they're not susceptible. But certainly keeping our public masking and distancing is important because we don't know who's vaccinated, who's not. And that's really a social norm that we should keep until we're more reached a larger proportion of the population vaccinated. And then keeping all the usual restrictions for unvaccinated together being with unvaccinated. Next slide. This is a just paper I want to put a plug in for. This was published today in the USA Today by myself and other colleagues about schools and the impact on schools of vaccination. I mean, it wasn't really about vaccination, it was about school safety, but I think the vaccination story with teachers and educators, that California has really prioritized teachers and educators, and all of this incredible, amazing what vaccines do for teachers and educators, I think is going to give us a lot of safety, sort of security as we go to open schools in this state. Children are not at significant risk of poor outcomes from COVID. As of March 3rd, actually 286 children have died from COVID in the US over the past year. That is terrible to have any death, but it is similar to the number who die of influenza, unlike adults, where much more, 520,000 deaths in adults in the US. So we have to think about children's effects of all the other effects of school closure when we make decisions on school closure, mental health, overweight, not having socialization. And I think the balance is really tipped. It's a human rights issue to really open schools now. And I'll end there. Thank you very much.
Thank you so much, Dr. Gandhi. And I know that you have to go to another meeting.
Well, I'll take some questions.
I do wonder if you could, thank you, answer one particular question that a lot of people have had is, tell us about pediatric trials and any guesses on when we're going to have a pediatric vaccine. I know that 12 and up is going to be different than the younger kids, but.
Yes. So, you know, the 12 to 15-year-old Pfizer and Moderna trials are fully enrolled, and we will get that that data out. I think they say late spring, and so I'm looking forward to that. Younger kids than that, I think it could happen. I mean, it depends on if parents are willing to enroll them in trials of younger kids, just because of all the data that I just told you that younger kids are not susceptible to COVID. That would be much later. That would probably be in the fall, but certainly, you know, with everything I just told you about vaccines, no need to think about kid vaccination for opening up schools.
Yeah, great. And then another question that is relevant for schools and other workplaces, that data that really suggests, should we still, once staff and teachers and employees at other companies are vaccinated, should we still have asymptomatic surveillance screening at these workplaces, or is that just going to be completely irrelevant?
We shouldn't, actually, and the CDC really gave us that idea yesterday by saying if you've been exposed to COVID-19, no need to quarantine. They would not say no need to quarantine if you know, they would say do some asymptomatic surveillance. So really this data on blocking even asymptomatic carriage is so powerful since the trials came out. I mean, this is just data point after data point that that no, it would asymptomatic surveillance testing in schools or workplaces or healthcare workers after vaccination would be a waste of public health resources.
Great. Thank you for that. A lot of people, you went back to the beginner epidemiology, and I was glad because many of us do need a review on that. A lot of people are really wondering, and I've heard, friends and people in the community and patients ask, how long does the COVID antibody last in studies to date? It's interesting that data, as you alluded to from Erica, that really looks at COVID antibody serology to say how many people are immune, but maybe you're suggesting that even more people than that are immune because the antibody wanes and we still have T-cell responses. So can you talk about the timing of that?
Yes, the best paper on this, this is my favorite paper of the pandemic, besides the one that showed that T-cells, the T-cell response you get from vaccinations will protect you against all the variants, the one I just showed you. But my second favorite paper of the pandemic is Jennifer Dan. It was published in Science from UCSD. And it shows T-cell responses after natural infection. And antibodies do go down over time. Actually, probably if you had asymptomatic infection, your antibodies may go down faster, but your T-cells don't, even with asymptomatic infection. In fact, the half-life of the T-cells are so long that it resembles what you'd get T-cell response after yellow fever vaccination, which you get once in a lifetime. So I'm pretty hopeful we're not going to need boosters of SARS-CoV-2 vaccines in the future. I think that what we've seen from natural infection, that we're going to have either lifelong immunity, or at least if we extrapolate from SARS, people have had T-cell immunity out to 10 years from SARS-CoV, the cousin of this. So at least 10 years or lifetime. I think we need to stop worrying that we're going to need all these boosters.
Okay, and some people are asking that, is there a way to measure T-cell response? Say, for example, you have someone who's really at very high risk for COVID from, an immune system disorder or something. Is there any clinical way to do that? It was done in the trials, but.
The way it was done in the trials was a very complicated research lab way to study these T-cell responses. There is this ELISA antibody called T-cell spot. And actually a patient just wrote me this morning and said, I because of a immunocompromising condition, I don't have antibodies. Is there a way for me to check? And I said, it is commercially available, so you could check that. And I do have a feeling we may end up doing this more in the future.
Great. That is really, really interesting. Dr. Wadford, can you pop on? I have some questions for you as well, if you don't mind.
I'm so sorry I have to go, but it was lovely to
Monica, thank you so much,
thank you.
as always.
Thank you.
Deb, thank you for all that really helpful information. And I have a few follow-up questions for you. You talked about the super mutator, which I think is a really interesting concept, this idea that these, people with decreased immune system sort of function as hosts, where you can have a lot of replication in one person. But I did read in the press in a New Yorker article recently this quote, and I just would love to hear your response to it. One expert said, the fact that different variants have independently hit on the same mutation suggests we're seeing the limits of where the virus can go. It has a finite number of options, and that's actually very hopeful in terms of how many more mutations we're going to see over time. What do you think about that?
I absolutely agree, because we are seeing what we call convergent evolution. And it is really, that's a good way to look at it, is it's the limit of what this virus can do to us. And it's done a lot to us. So I'm not going to exactly, we're done. But because we are, it's interesting, those variants of concerns, and one of the reasons I wanted to highlight the similarity between those 3 different variants of concern. They do have, the similar mutations. Again, this convergent evolution, and because of that phenomenon, it does give us an indication that is probably the best that virus can do. But I'm never going to undercut or undersell the virus in terms of its ability to evolve and adapt. But based on the similarities, I would say if we can produce a vaccine that will beat all of those, we're really looking good, and we are very close to that.
Great, fabulous. And where are we on sort of increasing the sequencing efforts here in this country? I read that the US is the 32nd in the world on sequencing rates. We're behind Gambia, Vietnam, Thailand. But I know this is something you've been working on from the very beginning. So how are we doing as a state and a country? And when do you anticipate that capacity to really ramp up?
So no, it's a great question, and it is a huge focus right now, and it really did highlight. I mean, unfortunately, this country has been just caught off guard and unprepared, unfortunately, since the beginning, and it's just been, very disappointing. But those of us in public health, we have done our level best to deal with what we have. And part of that deficiency has been certainly in the sequencing capacity. We recognize the need for sequencing. The testing task force in California recognized it in May. We actually established what we call COVID-Net as a network of laboratories throughout California that's composed not only of public health laboratories, but also academic institutions and philanthropic and private labs to try to address this need to sequence, because that's one way for us to know what that virus is doing in an evolutionary capacity. And it really, knowledge is power. And if we know what it's doing, we can try to anticipate the next steps and block it. And now with the variants, it really did underscore the shortcomings and where we were in terms of capacity. So California, even though I think it's neck and neck with Texas in terms of the number of genomes sequenced. So we're past 20,000 now, but California has 40 million people, right? So unfortunately, we want to sequence somewhere between 2 to 5% of the viruses that are in California. Is that determined by experts who are consulting with us on a bi-weekly basis? That 2 to 5% should give us an understanding of really what the circulating viruses are and what the presence of the variants of concern and interest are and how they're doing over time, because that's really what matters. So we are getting to that point. We have signed up labs. The funding is now flowing from the feds. And what are we hitting now? Supply chain issues that we did with our testing. So every step of the way, we've had obstacles and hurdles, but we're surmounting them. We're addressing them. And, so again, we're neck and neck with Texas, trying to get more. And I can tell you that I have my laboratory, my team has, we've amassed more than 40,000 samples that are positive that we're ready to get sequenced. We're just lining up the labs now. And so we're going to hit that capacity 2 to 5% soon.
Excellent. Well, I know you're working hard on that, and thank you. We only have a couple minutes. I want to ask one more question that people had, which is, how are these variants impacting our PCR tests, and are they changing the efficacy of those?
Yeah, no, it's an excellent question. And what we rely on here at the state and many laboratories, actually, I think the majority of laboratories are using polymerase chain reaction PCR tests that have multiple viral targets. So we're not relying on a single target, which is very wise because of the mutation capabilities of the virus. But one of the tests that we've used that actually, if you miss a target, they call it a target gene dropout, and that does give us an indication that potentially there's a variant there, and so it allows us to focus that and follow up on it. But for the most part, there's no problem, and the FDA is continually evaluating mutations and the impact on tests.
Great. Thank you so much, Dr. Watford. Unfortunately, that's all the time we have today for questions, so we have so many more. And I'd like to thank Erica and Monica who had to go, and especially you, Deb, for presenting your content and all the work you're doing. Thanks to everyone else who's listening in and taking the time to learn from our webinar. We will be adding an additional webinar this month to talk about the school reopening issue that Monica alluded to, which is so vital, and about pediatric mental health. So tune in on Tuesday, March 30th. We'll have some great speakers for that. And then we will be also on our regular schedule the second Tuesday of the month. So the next one is on April 13th, and we'll have some experts talking about post-acute COVID syndrome. And additionally, next slide, please. we wanted to just remind you that CMA has some other wonderful webinars and resources, and you can see that on the telehealth tipping point project, and there's a lot of information. The links are here too. So just to remind you, please do fill out your survey at 4 o'clock today, attest to your attendance, you'll get CME, and we'll send those out for you. Thank you as always, and have a great day.